Okay, good afternoon, good morning, good evening to our ICCPR community and our ICRR community as well for our first ever International Cardiac Rehab Registry Quality Improvement session. So first of all, just a big warm welcome to our International Cardiac Rehab Registry participating programs. Here you can see some of our initial programs and those who have already been certified by ICCPR as well. Although we do have some new programs since then. So I pardon that we're not here. And I know you'll be eagerly collecting data so that you can learn about the quality of your services as well. So to all of the rehab sites that are participating in the registry that are on right now, if you could just put a note in the chat saying hello and the country and the program that you're in, we would just like to recognize your participation. I know we have folks here from India and from Pakistan, from Malaysia. So please do share in the chat. And because this is our first quality initiative of the registry and that it is of interest to the broader ICCPR community, we did open this up. So I just want to welcome as well our council members representing the 43 associations shown here, but also our many friends in countries where rehab societies are burgeoning and we're looking to support and bolster all of your efforts. So for those of you who aren't familiar with the registry, I just wanted to quickly share with you a few resources if you wanted to learn more, but at the end, Dr. Abraham Babu will let you know about how to join if you're interested. But you can read all about the development and our variables and when they're assessed in a free open access article in Global Heart. We've now been open for a year and going, but almost a year and a half maybe. And that's why we're at the position where we can start looking at quality, because the programs do have some follow-up data entered now. But we've had so many accomplishments in our first year. So I encourage you to take a look at our report, which demonstrates those nicely. If you want to learn more about our quality initiatives, so this is one of them where we pick a topic based on the data to focus on for 6 months. There's other quality initiatives too built into the registry, so you can see those on our website. And finally, again, just that you're all welcome to be members of the registry. It's free to join. And there is information on the website about how to be a part and to join, but also as the co-chair of the registry, on behalf of Dr. Karam Turkadawi and myself, we're very encouraging and are here to answer questions and support you along the way. So what are we going to be doing in today's session? So I'm Professor Sherry Grace, and I'm a co-founder of the ICCPR from Canada. I'm a professor in the School of Kinesiology and Health Science and in the Faculty of Health at York University in Canada, and also a scientist and director of cardiac rehab research with the University Health Network. I'm going to start off by talking a little bit about why we need women's focused cardiac rehab and the data in the registry that bolstered us to start off on this topic. Then I'm going to introduce our three speakers who will give us some real on-the-ground examples of delivering women-focused rehab that I hope will inspire you at your program. And then at the end, we'll just give a quick synopsis of the ICCPR Women-Focused Best Practice Guideline recommendations. And then Dr. Abraham Babu, who is our quality improvement lead for the registry, will give us our concluding remarks. So women do often need cardiac rehab more than men. So men, of course, need rehab too. But there are factors such as gender bias in society, hormonal issues, physiology, for some of these reasons that women's risk factors are often a bit different in terms of their preponderance, in terms of there's some unique risk factors to women. We know as well that some of our tests are less sensitive in women, so we're not identifying it as readily or as early as we need to be. Women often have less studied forms of CVD. They have more comorbidities. They receive less aggressive treatment. Our dosing information for medication really is based on men, and women often have poor outcomes. So again, we really need to get them into cardiac rehab so they can benefit. And indeed, while we know everyone on this call is very well aware of the many benefits for morbidity and mortality of cardiac rehab participation, we don't have a lot of randomized data on the benefits of rehab for mortality in women because women are less represented. And these days, it wouldn't be ethical to randomize women to a non-cardiac rehab arm. But I wanted to share with you here some observational data from Canada, but this too is echoed by data in Brazil more recently. And this is a survival curve, and it really shows compellingly that for women who don't go to rehab and who aren't referred, they have the lowest survival, even compared to men. But if we can get women to be referred and complete cardiac rehab, they have the best survival. So there's really room for so much benefit if we can get women into cardiac rehab, doing even better than men. But unfortunately, women are less likely to be referred to cardiac rehab than men. And this is a systematic review of studies where referral was reported separately by sex. And what you can see here across all of the studies is that most of the point estimates show higher referral rates in men than women, and the overall point estimate is very significantly showing that with the kind of raw averages being about 49% of men referred and 39% of women in these studies. They are mostly from high resource settings, so we do need more data from low resource settings, and hence the importance of our registry. It's a real shame that we have this sex difference in referral because guidelines, even for women, strongly recommend referral to cardiac rehab for women. Even where women are referred, they are significantly less likely to enroll in cardiac rehab. And so here's a systematic review of studies where the rates of enrollment, so attending a first session, and men and women were reported separately. Again, you can see across the studies, mostly there is greater enrollment in men than women. And again, this is statistically significant with on average 45% of men enrolling and 38.5% of women. So then it makes, it makes us ask, well, how are we doing in the registry? So let me just launch our poll, and I'd like to ask everybody to participate and let us know what proportion of women you think are in the ICRR. You'll see I said that there's less women than men, so I put all of the options under 50. Great. Okay, so we'll give people a few more minutes, a few more seconds. Okay, I'm going to end the poll and share the results. So hopefully everyone can see that. You are all right. So the, well, not all, but sorry, the most of you were correct, with 20% of the participants in the registry being women. So I want to shout out to our highest performing centers. So we have a program in Colombia and in Mexico that have the highest percent of women of all the programs, and they've really stood way out front. Certainly Colombia has shared many of their best practices with us. So this begs the question, though, why are women less likely to enroll? And here's data from our cardiac rehab barriers scale, or CRBS, where there's about 21 barriers rated on a scale from 1 to 5, with 5 being the highest barrier and a great barrier. And so here I show the ratings in a data set by sex. And while men do have some areas where they have they endorse barriers to a greater degree than women, women's barriers are quite fundamental. So things like not knowing about rehab and not being encouraged. So again, reiterating this importance of the processes of how we get women into rehab. Women also were more likely to strongly endorse exercise as tiring as painful, transportation barriers and comorbidities as barriers to rehab than men. So then also there are significant sex differences in adherence. So here are studies where the percentage of prescribed sessions attended is reported separately in men and women. And again, similarly, while it's not quite as drastic, there is significantly greater adherence to sessions in men than women. But again, it's not quite as great a differential, thankfully, here. But every session counts, because we know each session attended is associated with lower morbidity and mortality. So this is still nevertheless important. So why would women be less likely to adhere? And again, this can kind of give us hints around how to tailor rehab to women's preferences and needs and be women focused. So again, this idea that women don't like to tire or experience pain when exercising. They don't really like the treadmills and cycle ergometers. They like other forms of exercise. They perceive it as male-oriented, as often there are more men in the room. They dislike being rushed, crowded, weighed. They like privacy, we need separate change rooms. They like support from staff, and they like the safety of being monitored during exercise. So what do we find in the registry? So we did look at number of sessions. We do collect number of sessions attended in each program by sex. We don't ask about percentage of sessions. Each program has a different number of sessions that they prescribe. But on average, we saw women attended about almost 13 and men 11. So it's not statistically significantly different, but it's just incredible that we aren't seeing a lower average for women. But the issue is it's still quite few, and we'd like to increase that. We also collect in the registry the percentage of patients that complete the program. And for those that do complete or don't complete, then we ask, for those who don't, we ask why. And so in low resource settings, many patients must return to work, and that's often a valid reason that they can't continue, or they have a clinical event and for valid reasons can't be coming. So if we don't count those patients, we have a very high average of 82.9% of men completing and 88% of women. Again, this is just it's very high, and again, higher in women than men. But the median for both is about 50. So it just shows us there is a lot of variation here. But we don't really, once we get our women in, we're doing a great job in these registry participating sites. Again, I want to recognize our highest performing centers. So in Brazil, in Malaysia, in Pakistan, and in Colombia, many of these sites are on. And then in terms of program completion, at our one of our sites in India, there are more women than men completing the program. So just to end a couple of points before we pass it over. So women-focused cardiac rehab, what is it? So along with my lab, we did a review of the studies of women-focused rehab in the literature, of which there are about 24 and counting. And what did they mean by women-focused rehab? So we tried to define it in terms of three different elements. First of all, some of them were kind of women only or mostly women. And this could be sessions that were women only, components of the program, or full programs. And we often saw then that the staff serving these women only components were educated and around women and heart disease. They are very empathic with women, patients specifically, and they provided patient-centered care. Secondly, often the content was tailored to women, so forms of exercise, and then also just really robust support and psychosocial components. And then often too, the education component was inclusive of women and also addressed some factors that are unique to women. Finally, they offered women choice of mode. So when we saw some of those barriers, transportation, et cetera, where safety isn't a concern, these programs offered women the choice of center-based or home-based or hybrid, and the choice of timing of their sessions to get around any family or other obligations due to women's multiple roles. There were quite a few studies as well that had outcomes assessment. And I really encourage you to take a look at our publication, and we'll show you where you can find it at the end. But there are many, many outcomes that we were able to report on. But here I focus on quality of life because that is often the most important outcome to women. And we were able to pool this data. So on the top here, you see a forest plot for physical quality of life, and on the bottom, mental. And these are trials, randomized trials, where women-focused rehab is compared to an active comparison. So traditional co-ed cardiac rehab, not usual care, but active co-ed rehab. And you can see clinically meaningfully higher levels of quality of life, both physical and mental, for women when they attend women-focused rehab versus co-ed rehab. So with that, let me pass it over to our speakers who are going to give us some examples of how they implement women-focused rehab in their programs in the real world. So first, Dr. Jennifer Price is Vice President of Clinical Programs and the Corporate Nursing and Professional Practice Executive at Women's College Hospital in Toronto, Canada. Dr. Price holds a PhD and an acute care nursing certificate, as well as a certified cardiovascular nurse certification with the Canadian Nursing Association. She's an adjunct professor with the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto, where she is involved with graduate education. Her clinical practice is in the area of women and heart disease at the Women's Cardiovascular Health Initiative, which is Canada's first, and I think also the first in all of the high-income countries of the world, the first women-only program that we're aware of. Dr. Joyce Ramos is an accredited exercise physiologist and a senior lecturer and course coordinator of the Bachelor of Exercise Science, as well as Masters of Clinical Exercise Physiology programs at Flinders University in Australia. Her main research theme is exercise as medicine. We're looking at prevention, treatment, and management of chronic diseases, with particular interest in women and cardiac rehab. Her current research involves the identification of needs and preferences of women in rural Australia to co-design a web-based cardiac rehab program. And they call this CREW, so cardiac rehab, especially for women. Third, we will hear from Hanita Menezes, who is, she's earned her postgraduate and undergraduate degrees in nursing at Manipal College of Nursing in India. She's worked as a staff nurse in Kasturba Hospital, Manipal, and as an assistant nursing superintendent. She is currently doing her PhD at the Manipal College of Nursing, and myself and Dr. Babu had the pleasure of serving on her supervisory committee for her women-focused electronic cardiac rehab program, which is the first to be tailored for low resource settings. So with that, let me pass it to Dr. Jennifer Price.
Thank you, Dr. Grace, and thanks to the ICCPR for the kind introduction. I'm delighted to be speaking here this morning. Well, morning in Toronto, but good day to everybody else. So I'm going to talk about our cardiac rehab program here at Women's College. We think it's Canada and North America's first women-only cardiac rehab. I'll talk a little bit about how we've designed it specifically for women and give you some tangible examples of how to tailor cardiac rehab specifically to women. Sherry did go over a few of these things, but we started our program in 1996, and at that point in time, women comprised only 3 to 15% of contemporary cardiac rehab programs. As Sherry mentioned, they were more likely to drop out and less likely to continue with healthy exercise regimes. And certainly female gender was a strong predictor of poor attendance and still is. And at that point in time, women were less likely to receive fewer referrals, they had lower adherence and higher dropout rates. And really what we knew in 1995 was that the traditional cardiac rehab program had been developed for middle-aged men, and so spoke to some of the things that Sherry talked about. It wasn't the right type of exercise. They felt a little overwhelmed. They didn't like the competitive atmosphere. The literature has continued to show that long distance and commute time is an issue, lack of insurance coverage, even where in socialized medicine like Canada, financial issues are big. Family obligations, role resumptions, denial, depression, and women are often older with more severe disease and comorbidities, but certainly in our program, we're seeing that drastically changing and have many women in their 30s enrolled in our cardiac rehab program. Physician endorsement and ease of access were predictors of participation, as was high self-efficacy, social support, and socioeconomic status. So in 1996, Dr. Sternberg, who was the division director of cardiology at that point, he and I had looked at all this literature, and we were concerned because while we didn't have a cardiac rehab program at that point, we did refer and had very few cardiac women actually attend. We talked to a lot of the women in the hospital's practice, and we heard things like they wanted to see other people that looked like them in cardiac rehab. They wanted small groups. They wanted social support. They wanted some really practical tips around diet and exercise. So we looked at our women's health principles, which were guiding the hospital at that point in time, and developed the program. So our women's health principles were things like empowerment of women, so informed decision-making, participation, and really included women. Even in 1996, we included women on our design team as to what our cardiac rehab was going to look like. We were then inpatient turning outpatient facility, and we actually engaged a female architect to help design the space for the women to work out in. We believed in accessible programs, so things like flexible schedules, sensitivity to culture and language. Flexible schedules, we are able, because we are a fairly small program, to add classes early in the morning or later in the afternoon to accommodate women, especially as we see the shift in demographics and we see women going back to work. So we can add a 7:30 in the morning class, or more like a 5:30 class, so they can come before or after. And we always have a class at noontime. We try to begin our care as soon as we receive the referral, and I'll talk a little bit more about that later. Continuing with the women's health principles, we have a broad definition of health, and we used to talk about women's health, and it used to be about breast cancer and gynae cancers. So we called it bikini health, but now we realize that heart disease is the #1 killer of women. But we also think about unique risk factors for women. So things like preterm delivery, hypertension disorders of pregnancy, gestational diabetes, autoimmune disorders, breast cancer treatments, and depression. So really thinking about how we look at those risk factors, how we assess them, and how we help monitor. Sherry talked about educated and empathic staff. We like to believe we do have compassionate, empathic staff. We often hire staff who have been students in our program because we know them and we see how they interact with our patients. We do have a small staff to patient ratio because we are a exercise equipment base. So it's 1 to 4, 1 to 5. Patients are not brought into the program in a group. They have a individual intakes, so they can, as soon as they're ready to start an exercise program, we can get them in. And we do have an interprofessional team with OT, PT, kinesiology, a social worker, dietitian, nurse practitioners to work on this. And we have many volunteers in the gym who are patients who are graduates of the program. So they are one of our best resources. So these are just a few pictures of the gym. This is actually our new space. We moved into a new hospital building about 5 years ago, so very privileged. So how, Sherry asked me to talk about how we actually get women to the program. We've moved in Ontario to a lot of automatic referral, but even in the setting of automatic referral, you don't see every patient getting to that intake assessment. And that was actually the focus of my PhD work a decade ago now, where I saw in one setting, even in automatic referral, less than 28% of women actually got to the program. So we do a lot of work with word of mouth through patients. We do a lot of community events. We go to churches, we go to schools, we go to universities, we get invited to certain women's events. Our team does community outreach to family physicians, diabetes education centers, really to help people understand the importance of cardiac rehab and what it does. We always have interdisciplinary learners in our program. So if somebody's doing a rotation in cardiology with the physicians, they have to come through the gym for at least a session to see what's going on so that they know what cardiac rehab is. And as I mentioned, once the referral is received, we actually begin the intervention, and one of our kinesiologists will reach out to the patient and do some health coaching around what is cardiac rehabilitation, what are the benefits, why should they come, help them talk through their barriers, and make referrals as necessary. We looked at our population to look at those patients who weren't coming, even with what we thought was a great program. And we saw about 25% of our referrals did not attend, mostly attributable to depression and arthritis, and distance and transportation issues were cited as well. So we now really look at addressing those transportation issues when we start our health coaching, offering things like TTC tokens. And we've also morphed to more of a virtual program as well. So I'm excited to hear Joyce and Hanita talk. So hopefully I can have some new things to take back to my program. We do have about an 85% compliance rate at discharge. So our program is 6 months. So we've seen a significant improvement in exercise capacity and quality of life at discharge and 6 and 12-month follow-up. We attribute it to the female-focused exercise training. We have a small class size. Sherry talked about women not wanting to walk on the treadmill, and we get that. We have lots of different equipment, including reclining bikes and things like that, so that it's easier on the joints. My physiotherapist does continually tell the patients, though, that they do have to walk, so being on the treadmill is good for them. And we do run virtual self-management education and support. That was in person pre-COVID, but now everything is virtual. We really use social cognitive theory and helping women develop self-efficacy, exercise mastery, and social support. It is a circuit training approach on traditional gym equipment because that's the room we have. We do focus on functional resistance training, push, pull, lift, and pick up with TheraBand's free weights. As mentioned, have a staggered entry into the program. Discharge planning and community maintenance is started at initial assessment. So we hope to get the women knowing what they're going to do next. We do take a gender lens and appreciate the life stages of women. We do have women, postpartum surgery. We think about that. We do have childcare available in the hospital. We have flexible hours. We do virtual sessions. We acknowledge the competing roles and role resumptions and try to counsel women on how they can continue to cope with exercise once they're out of the program, because many women do find when they're in the program, it's okay to go and exercise and somebody will help them do that. But once they're done, they don't have that same support. So in summary, we think that women's only program considerations can improve attendance and completion rates and lead to those improved outcomes we see with all cardiac rehabilitation. And that by taking gender into consideration through the lifespan, we enable successful behavior change. And thank you very much.
Thank you so much. Okay, so we'll pass to Dr. Ramos, and we'll leave some time for questions at the end. I unfortunately overspoke, so that was excellent.
All right, can everyone see that okay? Fantastic. All right, thanks, Sherry. So this talk will really give you an overview of our cardiac rehabilitation, especially for women project, also known as the CREW project, which really aims to co-design and evaluate a women-focused web-based cardiac rehabilitation service to ultimately improve cardiac rehabilitation adherence and completion in women. So first, I would like to acknowledge our CREW team, especially our lead investigators, Professor Robin Clark and Dr. Alini Baligali, as well as the Hospital Research Foundation for funding this research project. So just to give you a very brief background, as you're aware, cardiovascular disease remains the leading cause of mortality in women worldwide. And specifically here in Australia, cardiovascular disease accounts for about 30% of female deaths. And it's really highly attributable to high prevalence of modifiable risk factors, like, for example, smoking and diabetes. And alarmingly, smoking and diabetes rates in women living in rural and remote Australia is about 1.6 and 1.3 times higher than those living in major cities. And as you're all aware, cardiac rehabilitation is an established comprehensive secondary cardiovascular disease prevention program. And specifically here in South Australia, we have 3 different modes of delivery of this program. So we have face-to-face, telephone-based, web-based, and a hybrid of all these modes to really decrease that barrier for uptake of these programs. But our audit showed that women are still 1.2 times likely to decline cardiac rehabilitation due to barriers already mentioned by Sherry earlier. And specifically here in Australia, in rural and remote areas, socioeconomic disadvantage and access inequalities to services really contribute to the low uptake of cardiac rehabilitation in women. And so the aim of our CREW study is really to increase attendance and completion of cardiac rehabilitation in women living in rural and remote Australia through a co-designed web-based cardiac rehabilitation that is specifically tailored to women's needs and preferences. So our CREW project has 3 phases. Phase 1 aims to understand the cardiac rehabilitation needs and preferences of women living in rural South Australia through a qualitative phenomenological study, as well as a systematic review to really inform the co-design of our existing web-based cardiac rehabilitation service here in South Australia. And so for this qualitative study, 2-hour workshops were conducted across 6 rural regional areas of South Australia, which included a total of 19 women with cardiovascular disease with an average age of 69 years who had completed or were completing a cardiac rehabilitation at the time of our workshops. And the preset open-ended questions were used to really generate that discussion around the needs and the preferences of women for different aspects of cardiac rehabilitation delivery. So including social support, educational content, exercise or physical activity, medication adherence, and the costs incurred to actively participate in these cardiac rehabilitation programs. And data from these workshops were transcribed verbatim, and thematic analysis was actually performed according to the Braun and Clark's framework. And as you can see in this figure here, 6 themes were identified from these workshops. And there are a lot of things that I would like to share with you today, but in the essence of time, I'll just identify a few things that I found really interesting that are specific to women. So in terms of the financial concerns that were raised by women in these workshops, the costs incurred in attending face-to-face cardiac rehabilitation was recognized to be the need to uphold a decent appearance. So for example, purchasing the incurred cost for purchasing a decent gym clothing to actually participate in an exercise session. Another interesting item here is the recognized need of these women for a one-stop shop resource, particularly within a web-based cardiac rehabilitation. So a one-stop resource on financial assistance that are available during every stage of the cardiac rehabilitation. So for example, information on medication subsidy that they are eligible for, and available funding for daycare for mothers, for example. And theme 2 is around the importance of early education and support. And one thing here that I found really interesting was the need for an early education on the bra requirements following a cardiac surgery. And this is what they found would optimize their wound management. And in terms of nutrition, the need to include ideas for nutritional food recipes that they can actually share with their partners during their cardiac rehabilitation journey. And lastly, here is the mental health, so the need for early mental health support following a cardiac event. And theme 3 here is their preferred educational session delivery. So they prefer this to be more concise and more interactive to really provide that social support. And in terms of delivery, they prefer it to be delivered by a professional with expertise in the topic area, as well as using a combination of videos, text, and podcasts that we can embed within a website. And the podcast was very interesting for me and makes a lot of sense. In terms of exercise and physical activity, the elements that they prioritized was safety, enjoyment, and the use of technology. In terms of safety, they recognize the need for tailored supervised exercise session, particularly in the very early stages of cardiac rehab. And in terms of enjoyment, they recognize the need for inclusion of alternative forms of exercise, such as yoga, Pilates, and dancing and so forth, beyond the traditional forms of exercise, such as cycling and treadmill exercise. In terms of the use of technology, they were very open to the inclusion of exercise videos for these alternative forms. They found this really appealing and engaging, but they did say that they prefer to include that are